All right, let's talk about one of the heaviest hitters on the NCLEX, endocrine medications. We are going to break down what you absolutely have to know, the stuff that shows up all the time, the common traps they set, and the safety priorities that'll have you walking into that exam feeling like you own the place. Let's just jump right in.
Okay, let's put you right in the hot seat with a classic NCLEX scenario. Picture this. Your patient's blood sugar is 110. Their breakfast tray is still a whole 30 minutes away from arriving. And in your hand, you're holding a syringe of rapid-acting Lispro insulin. So, what's the move? This isn't just some abstract question. This is a real-life call that has immediate consequences for your patient's safety.
So why do we start with a question that feels like a trap? Well, because the NCLEX at its very heart is a safety exam. It wants to know if you can make the safest choice. Getting this right shows the test and, more importantly, shows you that you know how to prioritize and prevent a potentially dangerous situation. This is way bigger than just passing a test. It's about proving you're ready to be a safe, sharp nurse.
To even begin to answer that question correctly, you have to have a rock-solid grip on how insulin works. You know, the onset, the peak, and the duration. Look, I know it's a lot of numbers to memorize, but this knowledge is completely non-negotiable. It is the bedrock of safe insulin administration.
Okay, so here's the cheat sheet you gotta burn into your brain. Just look at rapid-acting Lispro. It gets to work in less than 15 minutes. That's literally faster than you can find a good pen sometimes. Now, compare that to long-acting Glargine, which just gives this nice, steady, peakless coverage all day long. The NCLEX loves to play with these timings because it's a perfect way to test if you can think ahead and spot risks before they happen.
So they're staring at all these numbers: onset, duration. But if you only have enough brain space for one, which one is it? It's the peak time, no question. The peak is when that insulin is working its absolute hardest. And what does that mean for your patient? It means that's when they're at the highest, absolute greatest risk for their blood sugar to crash.
And that crash leads us directly to our number one, top-of-the-list priority alert: hypoglycemia. This is hands down the most common and, frankly, the most dangerous thing that can go wrong with insulin therapy.
So what exactly are we talking about? Hypoglycemia is when blood sugar dips below 70. Now here's why that's a 5-alarm fire for us as nurses. Your brain runs on glucose. It's the only fuel it uses, and it has zero ability to store it. So when those glucose levels plummet, the brain is literally starving. That's when you see confusion, irritability, and if you don't act fast, seizures, a coma, or worse.
So how can you spot this before it gets out of hand? Easy. Just remember that your patient is going to look and feel tired. T is for tachycardia and tremors. They're going to be shaky and their heart's going to be racing. I is for irritability. They might get snippy. R is for restless. E is for excessive hunger. I mean, who isn't irritable when they're hungry, right? And D is for diaphoresis, which is just a fancy word for sweating a lot. You see these signs, especially around that peak insulin time, you check that blood sugar and you do it stat.
And now for a huge, classic NCLEX trap, so lean in for this one. A lot of our patients with diabetes also take beta blockers for their heart. While beta blockers, the ones that end in OLOL, can hide one of the biggest warning signs of hypoglycemia, that fast heart rate, the tachycardia. It's like the body's alarm system has been muffled. This makes your assessment skills 1,000,000 times more important. You can't rely on that one sign. You have to be looking for the others, like sweating and confusion.
Okay, let's load you up with a few more of these memory tricks, and then we're going to put it all together in a quick mini scenario to see what you've learned. Trust me, these little tricks are absolute lifesavers on exam day. All right, mixing insulin, a skill you'll do 1,000 times. There's one simple rule you can never, ever forget: clear before cloudy. And the easiest way to lock that in? Think RN. You're going to be an RN, right? So you draw up the regular insulin, which is clear, before you draw up the NPH, which is cloudy. RN. Clear before cloudy. It's a fundamental safety check.
Now for a rule that has absolutely zero exceptions. Are you ready? You never, and I mean never, ever mix long-acting insulins like Glargine or Detamir with anything else in the same syringe. Think of them as solo artists. They don't play in a band, they don't do duets. Mixing them messes up how they work and makes them totally unpredictable and dangerous. Just don't do it.
Okay, time for a little clinical detective work. Here's the scene. You have a client whose diabetes was perfectly controlled on their medication, but now, all of a sudden, their fasting blood sugars are sky high, like 180 to 200. You dig into their chart and see they just started a new med. So the question is, which medication is our culprit?
All right, here are your suspects. We've got prednisone, phenelzine, atenolol, and allopurinol. Go ahead, pause here for a second and really think about it. Which one of these is known for sending blood sugar levels through the roof? And the answer is prednisone. If you got that, give yourself a pat on the back. That's awesome. Why? Because prednisone is a glucocorticoid, a steroid. And one of the biggest, most well-known side effects of steroids is that they increase blood sugar, hyperglycemia. And hey, here's another great mnemonic for you, the 5 S's of steroid side effects. And one of those S's, you guessed it, stands for sugar. It's a critical connection you have to know.
Okay, take a deep breath. It is time for the rapid recap. We're about to fly through the absolute must-know, can't-forget takeaways from everything we just talked about. Are you ready? Let's go.
First up, if you're giving a rapid-acting insulin like Lispro, that food tray better be sitting right there at the bedside. You do not give the shot and then hope the food shows up. No food, no shot. End of story.
Remember this little phrase, the peak is the pit. When that insulin is at its peak effectiveness, your patient is in the pit of hypoglycemia risk. Know the peak, and you'll know when to be most worried. When you're mixing, what's the rule? Clear before cloudy. Just think, RN, regular before NPH, every single time.
And what about our long-acting insulins, like Largine? They are loners. They fly solo. You never ever mix them in the same syringe.
Don't you forget that beta blocker trap. They hide the tachycardia, that racing heart. That means you have to use your nursing eyes and assessment skills. Look for the sweating, the shakiness, the confusion. Watch your patient, not just the numbers on the screen.
And finally, steroids like prednisone will make blood sugar spike. If your patient with diabetes starts a steroid, you need to anticipate that their glucose levels are going to climb and they might need more insulin. So let's bring it all the way back to where we started. You're standing there, Lispro in hand. Your patient's sugar is 110, and that breakfast tray is still 30 minutes out. What do you do now? You know the answer, don't you? You know that Lispro starts working in less than 15 minutes. So you absolutely 100% hold that dose. If you give it now, that insulin will peak long before the food ever arrives, and your patient's blood sugar will bottom out. Holding that dose is the safe answer. It's the right answer, and that is exactly how you need to think to crush the NCLEX.